Thank you very much. I know it's very late, so I'm trying to be fast. This is a complex case with severe aortic stenosis and a complex coronary artery disease. 72-year-old man with symptoms of heart failure and angina, who has a past medical history of diabetes and presented after 2 months after an extensive anterior inferior MI, which underwent unsuccessful thrombolysis in his local hospital, and present also with ventricular, arrhythmias. He's on all these medications for coronary artery disease and heart failure, and actually after two months after the MI, he's in a pretty good shape. He's tired and has some, symptoms, but not very severe symptoms. This patient underwent this coronary angiogram, which showed a pretty good right coronary artery, and you see the PDA doesn't go all the way up to the apex. That's why he presented with anterior inferior MI, because there is a wraparound LAD. This is the left system, which see the total occlusion of the middle AD. After a huge diagonal, which has a very severe stenosis ostium. So the patient was sent to our surgeon to have a AVR, surgical AVR, and the coronary artery bypass surgery. But before the procedure, before the surgery, our surgeon asked for a test, for a functional test, to see if there is any viable tissue on the LAD region. So he had the ejection fraction is very low, 25 to 30%, with mild MR and pretty normal pulmonary artery pressure. The aortic stenosis is very severe. Even with that low ejection fraction, he's able to generate a Vmax of aortic valve of 4 meters per second. So our surgeon asked for a SPECT, which showed non-reversible ischemia. Actually, it was a scar in the arterial apical and inferior apical left ventricular wall. So she asked for an evaluation from the TAVI team, and we thought that actually this patient was a good case for TAVI and maybe coronary artery revascularization in the future, because of the low ejection fraction, the scar in the LAD region. So what are the problems with this patient? He's 72 years old, and if we have to do something, we have to be very, very good on what we do. We have to have a very good acute outcome, so the index procedure should be very optimal, with no paravalvular leak, with no residual gradient, and actually no need for pacemaker implantation, because he has a very low ejection fraction. And on the other hand, he is 72-year-old, so have to have a lifetime plan. Have to have good coronary access, because we may need to have, and we will need to have a PCI in the future, maybe in the near future. Has to have a durable valve, and if in the long term needs another valve, to have a good option with another TAVI procedure. So first of all, let's see if he's good for a TAVI. Let's say if he has good peripheral access, because if he has no access and we have to do a transapical procedure, so there's maybe a lot of benefit with TAVI compared to surgery. So he has good femoral access, and the left is better than the right one. So I think we start well. And the anatomy is pretty good, without any major obstacles for a TAVI procedure. has moderate calcification with good, with spacey aortic root. But also has a severe coronary artery disease. So what's best to do first? Let's do the TAVR first, and then try to take care of the coronary artery disease, or to a PCI first. Actually, what we see from a couple of studies is that if we do the PCI first, there is no any benefit. And actually, if we do a complete revascularization, let's say that we have a complex coronary artery disease and have a revascularization with a residual syntax score less than 7. So actually the outcome is worse, because we put a lot of stents, and we may have to go back again later on. We may have some problems with access. So the plan is to do the TAVI first, and then to see what we have to do with the coronary artery disease. He's 72 years old, so we have to have a TAVI which is durable. The best results is with actual Evolute system, as we've seen, with a 10-year outcome comparable to the surgical valves, and we have pretty good actually results with the accurate system. We have severe coronary artery disease, so we have to take care of some time later on. So we have to put a valve which has the best access, the best possibility for access to the coronaries. And actually the best valve for that is the sapien valve compared to the others. If we put a self-expandable valve, we have to have a commissural alignment for the future, for coronary access to the future. The best one is for commissural alignment is the accurate Neo system with 97% alignment, good, very good, or good alignment. And the worst is the sapien with 50% alignment, but we don't care about that because we have the access very good with to the coronary, so the alignment doesn't have any significant impact on that. So let's see the anatomy now. It's a 26 annulus, 26 millimeter annulus in diameter, with a 35 millimeter of coronary sinus, sinus of Valsalva diameter, which means if we put a valve 26, 27, and we need to put another valve in the future, the VCD will be 4 to 5 millimeters. So it's a good option for the future if we need to put another valve. Also, the coronary sinus, the LVOT is almost the same diameter with annulus, and we see that the sinotubular junction is 24 millimeter above the annulus, so whatever valve we do is pretty high, and we have to, if we put another valve, we have a good access to the coronary arteries if we revalve in the future. And it's pretty spacious actually, it's 30 millimeters, so we put a valve now and we need to do a revalve. The valve to sinotubular junction distance will be more than 2 millimeters, so it will be good for the future. So what have the advantages and disadvantages of each of the valves? We decide to put sapien 3 valve because of the great coronary access option in the future, with pretty good results on durability and revalve options. Here's the case. Under ultrasound guidance, we do the puncture, and we put the prog lights and the sheath, the big sheath. So we don't have any, it's a spacious arteries, and we don't have any problems pushing the sheaths. This is the gradient before, 40 millimeters of gradient before the valve, Safari small wire. But when I try to push the valve in the sheath and advance it, I couldn't do it. I mean, I forced very, very much, and I couldn't. The valve couldn't go below, above the proximal part of the sheath, And if you see here a close look of the valve during pushing, you see that something is sticking out and actually goes towards the sheath, towards the walls of sheath, and couldn't go in. The valve couldn't go in. So probably it was a loading problem of the valve and prevent from going in. That's why I had to take care of the whole system, to take out the whole system, and put another sheath, 16 French, and a new valve, 26 millimeters Sapien 3 valve, which eventually going very well without any problem. Position the valve. It's a good position, inflate, opens well. Deflate the balloon. Where we see that we have a moderate paravalvular leak, and we don't want, absolutely we don't want that, because the patient has an ejection fraction of 25 to 30%. So we're going to have absolutely none paravalvular leak, so that's why we dilate with the same balloon, putting 1 millimeter more contrast. Post-dilate the valve. Now we have a good result without PVL. The gradient is 0. So the index procedure is successful. We have, as you see here, we have LBBB, which after 10 minutes resolved, and EKG went back to a narrow QRS without AV block. We closed the artery without any problem. And the patient actually has a good result with a Vmax of aortic valve 1.9 next day, trace or no PVL. And he did very well in the near future with improvement of all the symptoms. But we have the coronary artery disease, and we have to take care of it, I think, because he has a major branch with a severe stenosis, and he cannot afford to lose any more myocardium. We brought him back in 3 months, and we took a picture to see how the coronaries are. The RCA is the same, and you see the left coronary system with a significant, very severe stenosis in the viable major diagonal. And if we see the next picture, and actually after I freeze it, see the small, the narrow arrows are the obstructed vessels with the collaterals, filling from the collaterals, actually which represent the scarring myocardium, non-viable myocardium, and the big arrow is the big diagonal which supplies the viable myocardium. So it's a pretty good vessel. That's why we decide to open it. But, the most important thing is we cannot afford any complications. If the vessel closes during the procedure and we don't put a stent very quickly, we may have very, very severe problem. That's why we didn't do any heroic attempts. We put a balloon and try to see if the ostrom of the vessel could be dilated. And actually, after we see that the vessel was not dilatable, we decide to do rotablation. That's why I put a Mamba microcatheter exchange for a rota wire. And then do a rotablation with then 1.25 burr. And after that, try to put a balloon, try to put a stent which couldn't go. So we proceed with IVL, shockwave, which actually did pretty well, and put a stent. But in this patient, we have to be absolutely perfect. We have to put a stent which is very well deployed and expanded. That's why we checked it with IVUS to make sure that everything is okay. And we found that the stent is underexpanded. 2.75 stent up to 3 millimeters was underexpanded distally and proximally. So we post-dilated with a 3.25 balloon distally and a 3.5 balloon proximal, with a good result, as we see here. The steno is well expanded and diapposed, and we have a very good result on this diagonal, which is a big and a very significant vessel for the patient. The patient did well, and actually he's doing well now. Thank you very much.
Thank you, Nektarios, who's a very difficult patient, complicated patient, heart failure, AS, coronary disease, recent MI, and you did a very nice, complex coronary procedure to help him to save his ejection fraction, his cardiac output. Are there any comments?
I think the idea, yeah, Vasilis, I think the idea in this very depressed ejection, LVs, to do the coronary revascularization after the TAVI, it's a good idea, because in other situations you might have a patient collapsed after a vagal episode or whatever. So, Vasili, you want?
Microphone.
It's on you.
It is available in the US, the new FX Plus device with 2 openings at the site of coronary arteries. So it's a good idea to have an alternative in this case.
I think it's a very nice comment. And
unfortunately, this device is not approved in Europe and, of course, in Greece.
Very nice comment.
So, great and very complex case and great result, both the coronary and the TAVI. It was also a good idea to exchange for the 16 French Edward sheath. I found sometimes when it's too tight with the 26 valve in the 14 French, I found there's this dilator that comes with the sheath is a 16 French dilator, so just dilate the sheath before I put the valve in, and that sometimes makes it easier. Just something that I found that it helped me a couple times when I had hard time pushing.
Yes, or use the Kochaeli technique. The Kochaeli, it's given
really propofol will work.
Exactly.
Exactly. Really, inside the sheet.
Okay.
Sorry, it's very, can I comment? Exciting case, very well done, very well performed. And actually, it demonstrates the tendency that exists to treat the severe aortic stenosis first and then deal with the coronaries. Because imagine in a patient with low ejection fraction, severe aortic stenosis, you have to do an aortic ablation. The patient may die on the table. So it was a very wise decision, and actually it demonstrates that in these cases we have to sort out the aortic stenosis first, irrespective of what type of valve we use, because we saw in the previous case that the access to the coronaries, there is no problem.
Good, Petro. I think we have to adjourn the session. So thank you, Nektari. Thank you, Petro. Thanks everyone for staying up so late or contributing.